Well, hello everybody, this is Dr. Medicine RX, and in today's video, we'll be discussing part 2 of ANCA mediated vasculitis, that is Churg-Strauss syndrome or eosinophilic granulomatosis with cholangitis. So, EGPA is also known as Churg-Strauss syndrome. It is a type of small vessel vasculitis, and the most important thing that we have to point out here and the characteristic feature of Churg-Strauss syndrome is that it is associated with asthma and eosinophilia. So the most common age group it presents is in adults, obviously in the age group of 40 to 50 years, and there's a slight male predominance. So the person gives a history of asthma since their like adolescent age or their 20s or 30s, which eventually progresses into this syndrome. Allergy plays a really important role. That does not necessarily mean that every person with allergy develops Churg-Strauss syndrome. It's just that in some individuals there's genetic predisposition, and also there's a heightened allergic response, that is the Th2 response. So Th2 response in turn increases and produces interleukins such as IL-4, IL-5 and IL-10, and here IL-5 is an important eosinophil interleukin, so it increases the production of eosinophil, which, as we all know, are the cells involved in allergy. So coming to the clinical features, we've got them divided in three phases. The first one is the prodromal phase, and this is essentially seen during their adolescent age or during their 20s. So here the patient presents with a heightened allergic response. So there's allergic rhinitis, asthma and nasal polyps, and this phase usually it prolongs for many years. The patient usually is presented to the ENT department, and they usually have only allergic rhinitis and asthma, and as a result of increased duration of allergy they can also present with nasal polyps. Next up, we've got the eosinophilic phase, slightly begins in like their 30s or 40s. So here we've got peripheral eosinophilia along with respiratory tract infections and sometimes gastrointestinal tract symptoms. Next up, we've got the vasculitic phase, which we see in 50s and 60s. So here we've got the main manifestations, that is a systemic involvement. Here the involvement is seen in various organs, but the cutaneous features we can see in the form of palpable purpura, nodules, livedo resmosa, livedo reticularis, and sometimes necrotizing lesions. And of course, the other systems such as CNS and kidneys may also be involved. So there's CNS and renal involvement and their respective symptoms. So coming to the criteria, we've got American College of Dermatology classification, ACR classification. So presence of 4 or more of the following criteria. We can think of Churg-Strauss syndrome. We can diagnose the case as Churg-Strauss syndrome. So first off, we've got asthma. Then there's eosinophilia, which is about more than 10% of the differential count. Then we've got mono or polyneuropathy. Then we've got non-fixed pulmonary infiltrates on chest X-ray. So these infiltrates, they're not usually fixed. They may be present in one location at the initial stage, at the initial investigation, and when we do a repeat chest X-ray, they may be seen at some other location. So there's non-fixed pulmonary infiltrates. Then we've got paranasal sinus abnormality, and we've got the final criteria, biopsy showing extravascular eosinophils. So the peripheral eosinophilia is essentially what that is mentioned here. So next, coming to lab findings, so obviously there's peripheral eosinophilia, there's increased IgE levels, and then P-ANCA, which are formed against myeloperoxidase MPO, are the main lab detection findings here. EGPA can have either P-ANCA or C-ANCA, but P-ANCA is the most important and most commonly found. So on chest X-ray, we've got pulmonary infiltrates. On PNS, that is paranasal sinus imaging, CT scan, we can see sometimes there's inflammation, there's bone involvement in rare cases, and then on biopsy we see vasculitis of both arteries and veins. There's vascular and extravascular granuloma and eosinophilic infiltration of the tissue. So coming to the management, here the chances of survival are really better. The prognosis is very better when compared to other forms of ANCA mediated vasculitis. However, the relapse rate and the recurrence rate is very high. So the patient usually they go into remission, but it's very difficult to maintain remission, and sometimes uh, nothing really works. So, however, the first treatment of choice is that we start with methotrexate and prednisolone, obviously immunosuppression. So 20 to 25 mg per week of methotrexate and 1 mg per kg per day of prednisolone are the initial treatment that we go for. Then if there's a localized involvement, but if there's a systemic involvement present, then we have to go for a higher immunosuppressive drug such as IV pulse, cyclophosphamide along with prednisolone. And then if it's refractory, if it is not responding, if it is responding but it is not responding well, if it is relapsing or if it is not responding, we can go for monoclonal antibody rituximab, that is 375 mg per meter square per week for 4 weeks, that is 1 month. So if at all we achieve a, you know required response, then we can maintain the remission phase by giving azathioprine and methotrexate. So this was in brief about EGPA. I hope I have done justice to this topic and I have provided all the required points. For more such crisp content, do subscribe to Dr. Medicine RX. Bye bye.